Ladies and gentlemen, it's time to start the session. It's a real pleasure to participate at this session on winning. This is the session without any slides, just a discussion together, and therefore feel free to ask any question. My name is Arnaud Thille. I work at the University of Poitiers in France. And
good afternoon, ladies and gentlemen. My name is Domenico Grieco. I am an intensivist in Rome, and welcome. So, shall we start? So the topic is extubation failure, and we are ready for opening the discussion. Anybody wants to start from the audience? No. Okay, I will start with a question. So the title seems to be extubation failure, right? Is it really? I would start from the basic. Is it really an issue to reintubate a patient after extubation? What are the risks related to that?
For me? Yes. What do you think about that? Reintubation is really a problem in clinical practice? Yes, we have lots of data showing that mortality is particularly high. Reintubation is not so frequent. In overall, the risk is around 15%, maybe from 10 to 20% according to the type of units. Maybe lower in surgical patients, a little bit higher in medical patients. Maybe we will discuss about risk failure for extubation. But extubation failure, defined as reintubation, is really a problem because mortality is around 30-35% in patients requiring reintubation. But it's true that we don't have a clear definition because we have old consensus defining as reintubation, use of non-invasive ventilation, or death. Obviously, death is a real problem. Reintubation also, but non-invasive ventilation is now often applied as a prophylactic manner, and therefore probably that non-invasive ventilation is not per se associated with poor outcomes. And I think, in my opinion, the real problem is reintubation.
So you introduced NIV, so prophylactic NIV, and I was curious to know, how many people in this room use high flow after extubation or NIV after extubation? So high flow, so everybody, no, 50%. And NIV after extubation? And how do you, now I would like to know, how do you select patients to use NIV or high flow?
First, we take in account the comorbidities of the patient, the biotype of the patient, and our impression of how he's going to be able to breathe on his own. So the difficulty of breathing, the prevision of the needs, we try to anticipate and give him non-invasive pressure. And if we think he could maybe benefit from a clear, how do you say it in English? Sorry, elimination of secretions. Sometimes you can use that high flow for the high heat, high humidity to increase it.
So you base your choice based on the comorbidities mostly, right? Okay. And Arnaud?
Maybe another opinion from the audience or another? No? Feel free to ask questions. We have only 30 minutes to discuss. And yes, okay. Okay.
Generally, a patient with COPD, for example, we do extubate on NIV, or patient who has got some myopathy and they need some support after extubation, NIV or high flow.
Another comment?
Actually, two questions. Do you have in your unit protocols? So do they have to achieve certain points to allow your patients to do extubation? And do you use ultrasound for the diaphragmatic evaluation?
So I first respond. So sometimes we use diaphragm ultrasound, but not so commonly after extubation, at least for myself. And the other was, sorry? Yes, we have protocols, but I fully agree with what he said, because he classified at least, I think, COPD and patients with cardiac diseases, and for those patients we use prophylactic NIV, so by default. And I think this is reasonable, and this is, I think, emphasized, but about the literature. Maybe also obese, right? No?
In our unit, we applied non-invasive ventilation. I have a bias because we conducted a randomized control trial, and we designed the protocol and we applied the protocol in our unit as in the study, and therefore we applied systematically non-invasive ventilation in patients aged of more than 65 with underlying chronic lung disease, COPD, but also obesity, hyperventilation syndrome, and cardiac disease, ischemic cardiopathy, left ventricular dysfunction, atrial fibrillation. And after the study, we found a significant decrease in the risk of reintubation by applying non-invasive ventilation in this population. We applied exactly in this situation. We found after that patients with hypercapnia, obesity, COPD patients were probably patients with more benefits of non-invasive ventilation, but we keep the same inclusion criteria as in the study and as in our unit. And the other study by the Spanish group, Gonzalo Hernandez, mixed several risk factors, chronic lung disease also, cardiac, but comorbidities or severity score or difficulty to manage secretions, obesity, and but in fact, obesity is not really a risk factor for reintubation. And in a recent meta-analysis, patients with obesity has decreased risk of reintubation, not an increased risk of reintubation, probably because they are very good responders to non-invasive ventilation. And therefore, for example, in our subgroup analysis of our study, we found rates of reintubation very low in patients with obesity, even if they had comorbidities and chronic lung disease.
And in this context, I would say this is something similar to what we saw for the WinSafe, which is the large study conducted by the Isicem on winning strategies in intensive care units worldwide. And similarly to what Arnaud was saying on obese patients, they found that a protective role of cardiac diseases. So patients with cardiac disease were less likely to be reintubated. And I think this concerns with a huge benefit from NIV. And I wanted to ask you something always when I meet you. And if you decide to extubate a patient on high flow, so no need for NIV according to the criteria you defined in your trials, and you extubate in high flow, and he or she develops acute respiratory failure 6 hours, 10 hours following extubation, do you apply, in that case, not prophylactic, but rescue NIV?
Maybe it would be a good question for the audience. Who would apply non-invasive ventilation as rescue therapy in this situation? Only you? No. And the others, you'll continue high-flow oxygen therapy, for example, or yeah, okay. First, probably it depends on the definition of post-extubation acute respiratory failure, but maybe we can talk about a patient with a respiratory rate of 25, high, but not so high, not very close to intubation, and maybe it could be possible to just continue high-flow oxygen therapy because we are not just to decide intubation. But in this situation, to answer the question, I will include in our protocol we are conducting, because I'm very sorry, but we are conducting a randomized control trial for this question in many ICUs in France, in patients with two criteria among the following: a respiratory rate above 25, clinical signs of respiratory distress, or respiratory acidosis, with a pH below 7.35, or a PF ratio below 150 millimeters of mercury. And these patients, we randomized to receive high flow nasal oxygen or non-invasive ventilation, because there is no consensus. And as you know, last recommendation recommend that NIV should not be applied in these patients because maybe it could induce deleterious effects and increase risk of mortality. But this is supported only on 2 randomized control trials performed more than 20 years ago. The first one by Keenan, a Canadian, 80 patients and no difference, published in 2002. And another one by the Spanish group, by Andres Esteban, published in 2004. And in this study, they found that patients treated with post-extubation respiratory failure, treated with non-invasive ventilation, was higher mortality as compared to those treated with standard oxygen. And I think it was a very important study because in the success story of non-invasive ventilation from 90s with beneficial effects on COPD patients, cardiogenic pulmonary edema, and then some forms of acute respiratory failure, immunocompromised patients, etc., this was the first study showing that non-invasive ventilation may increase risk of mortality in these patients. But in clinical practice, just in recent studies, around 30 to 40% of patients who develop post-extubation respiratory failure are treated in Europe with non-invasive ventilation. And therefore, this is an open question. Clearly, we don't have any strong data.
So maybe.
Sorry for my long.
No, absolutely. And then I come back to you. Come to you. And your hypothesis is NIV or high flow superiority?
I'm open. We designed the study with in favor of non-invasive ventilation because in the post-hoc analysis of our previous study, we found a signal in favor of non-invasive ventilation. But clearly, I don't know I cannot. Yes.
Please.
Very simple. Was there a risk benefit though? So you're thinking about going from high flow to NIV, but what's the risk benefit to just intubating that patient who are not clearly correct for being extubated? Are you looking at that from a risk benefit perspective as well? Thank you.
The risk benefits between NIV and reintubation? So I start and I come to Arnaud. So if I understood correctly, your question was, if you're on high flow and you go to NIV because of to avoid intubation, what are the risks and the possible benefits? So to me, the risk is if the patient is hypoxemic, the risks are related to the delay in intubation, as it is for NIV in de novo acute hypoxemic respiratory failure. For the benefit, I think this is something relevant, which is avoidance of reintubation, so shortening the duration of invasive mechanical ventilation, avoiding paralysis, sedation, and ICU-acquired weaknesses, and so on. So, yeah, I think it's a strike balance. I think maybe just for a suggestion, what we do in clinical practice when this scenario occur is that we apply an IV, but we have strict monitoring criteria. So we check respiratory rate, PF ratio, dyspnea, because we know that there are risks related to the possible intubation delay. And what do you think? Other risks?
I completely agree. We don't have the response, but probably the best way would be to intubate when patients meet your intubation criteria. And maybe, for example, in the study, we decide intubation in case of respiratory rate not 25, but 35, pH below 7.25, or PF ratio below 100, etc. And maybe in case of these criteria are meeting, intubate the patient, regardless the treatment, the prophylactic treatment before and...
What about, is it different for patients who develop acute respiratory failure after surgery? I mean, patients who are extubated after abdominal surgery and develop maybe pneumonia or stuff like that, do they have a different behavior?
And in the audience, do you apply non-invasive ventilation in these post-surgical patients? I think it's a very important point. We have data in favor of non-invasive ventilation in this situation, but we clearly have to distinguish two situations. Before, we were talking about patients in ICU, regardless the reason for admission, surgical, medical, but with a prolonged duration of mechanical ventilation. And for example, in the study by Esteban showing deleterious effect of non-invasive ventilation, patients had a prior mechanical ventilation of 6-7 days before extubation, and therefore ICU patients. The other literature, for example, from Samir Jaber, showing that non-invasive ventilation is beneficial in this situation in post-surgical patients, but they developed respiratory failure within the first hours after surgical procedure. And in this situation, probably the main reason for respiratory failure is pain, atelectasis, and in this situation, non-invasive ventilation was beneficial with a decreased risk of reintubation as compared to standard oxygen. But we have to keep in mind that surgical patients, for example, developing respiratory failure within the first 24 hours, and ICU patients, medical, surgical, after several days of ICU, and really patients, ICU patients. I think it's a very different situation. What do you...
Yeah, I think so. I mean, for maybe after elective surgery, if they develop acute respiratory failure, especially abdominal, I would go straight to an IV. The ICU patients may be different. You had concern, or she had concerns as well?
Me, no.
You have concerns?
No. No.
We were actually trying to study that, and we had a student who came to do a small investigation, and we tried to watch people who went into laparoscopic surgery, so intra-abdominal pressure, and try to see if we went straight to high flow, if we can diminish the sensation of this knee for one side, and by the other, we tried to see if we had differences in the ROH ratio, so P to VO2. But what happened, we had such a small number of patients, we could not take a lot of conclusions. But if you think that almost all of these patients will have some degree of atelectasis, and we decided to get away from the obese and the COPD, who surely would have it. But now that we were looking at going again at it, we're going to include those patients, and surely in those, if we can give them time to resolve the atelectasis, which will resolve spontaneously, just give them time to get back to their normal state, and maybe we could shorten the time to stay in the post-anesthetic unit or even ICU. So I think in those...
So it's high flow versus conventional?
Yep, we just for 1.5 months do whatever you want, and then the other 1.5 months go straight from laparoscopic surgery to high flow. But there were too small patients to take conclusions.
I think also another difficulty in generating evidence for elective surgery is that in ICU patients you have a very high, a relatively high rate of complications after extubation. So the possible benefit that you can achieve with a technique is easy to see. Not so easy, but at least with numbers that can be enrolled in randomized trials. For patients during surgery, you have such a small effect that you would need 20,000 patients, and maybe it's not working either, no?
Yeah.
Questions?
About,
and I always had a concern, if patients have kind of upper gastrointestinal surgery, so stomach, esophagus, and stuff like that, do you apply an IV? Huh. Finally, I found the questions that...
I don't have these patients in my unit first, just after. And I don't know. It's we come back to benefits and risk. If maybe non-invasive ventilation could be beneficial if in case of atelectasis, and maybe you can have a real benefit and avoid reintubation. But I don't have a clear answer. And you, what do we think? What do you think? What do you think?
Difficult, maybe with a nasogastric tube to drain the air in case of asynchronies, but I think there.
Pressure are not so high.
Yes, right, but yeah.
I was just saying that before we have that kind of patients on our unit. If it's a gastrectomy, we use it with lower pressures under the esophagic pressure. We use it. If it's esophagectomy, we don't use it. So gastrectomy, yes, with low pressures, but we use it, yes, if it's a failure use, and it's okay. We talk to the surgeons and yeah, as rescue, yeah. What? Yes, to avoid to intubate, yeah. I flew, yes, too, yeah, because the pressure is even lower, so yeah.
Would you ever consider extracorporeal carbon dioxide removal, ECHO, in those kind of patients? So you desperately don't want to intubate this person because you know what's going to happen. And so would you consider that as part of your strategy, as a tool?
In theory, one could consider. But there is also one great, besides I think it's maybe not so proportional to the disease, no intubation or CO2 removal. But you also have the issue, especially in surgical patients, about anticoagulation. So really difficult to think about that. No?
We don't use it.
You don't use it. Okay. And I wanted to ask, who uses HMEs and who other uses heated humidifiers for NIV in these patients? I mean, the filter or the heated humidifier? Or nothing. So who uses the filter? Raise the hand. For NIV after extubation. Sorry? No. With high flow, you need the heated humidifier. No. With NIV. So who uses the filter? Raise your hands. Up. So 50%. Who use heated humidifiers? Some. You use in all patients?
Yeah.
And do you think there is any difference between the two?
I have conflicts of interest because with Fischer and Pagel, and I like Fischer and Pagel, but and we have heated humidifiers on all ventilators, and therefore we apply only heated humidifiers. This is the first question, but there is advantage for dead space and work of breathing and potential better humidification. We don't know if it's really mandatory to apply humidification for these patients because using non-invasive ventilation patients had ability to humidify with upper airways, but probably mural gas is very dry and flow is very high, and I think it's in theory it would be better to apply better humidification with heated humidifiers, and then the advantage with dead space and work of breathing, and also because a new version. There is no alarms, etc. When you go to a tumor densitometry, and there is very low risk of switch off the heated humidifiers, and therefore in our unit, I'm very sorry, we use only heated humidifiers.
As a matter of comparison, in your opinion, as regards a patient with not having a clear conscious after extubation. He is conscious, but with a degree of delirium or some GCS differences. Glasgow Coma score, yeah? Differences. You think non-invasive or high flow is more suitable for him?
Patients with altered consciousness, yes, but I think it's very the situation most dangerous to apply non-invasive ventilation, especially after extubation. And for example, in the study we are conducting, a Glasgow below 12 is clearly an indication to intubate in the study we designed. And maybe it could be different in case of, I don't know, even in COPD patients, I think altered consciousness is really the most dangerous situation. No, you don't agree? Oh, okay.
No. I mean, yeah.
Okay.
Yeah, maybe yes, because at least in our place, maybe in our place, we try to use high flow when the cough is an issue, no? Because maybe it can facilitate cough. I wanted to say something. No. Regarding the COPD with altered consciousness, I think a short try for 1 hour or 2 hours to see what happens to the pH and PCO2 is worthwhile. We have some data, but not randomized trials. But I think you have to monitor the patient, but I think it's fine.
Just one remark. The risk of intubation in COPD at admission for acute respiratory failure is around 15%. The risk of reintubation in a COPD patients with post-extubation respiratory failure is 50%. And it's completely different. We cannot apply all data on COPD patients on COPD patients after extubation. It's a completely different situation.
And yeah, right.
That's the number that gives us that risk-benefit consideration, though.
So you're leading the session with that. And I wanted to say something about heated humidifiers. And I agree with you, also because you know that filters work well if you don't have leaks. In case you have leaks, you need heated humidifiers. And obviously all the physiologic studies on filters, there were 3 fellows or students looking at the patient and looking for the leaks and trying to avoid them. So I think in clinical practice, leaks is a more frequent issue than we can think from the studies. And also here there is a nice study from Gonzalo again last year in intensive care medicine in which they apply NIV continuously in very high-risk patients, so very old, very cardiac or respiratory severe diseases. And in that study, NIV was applied continuously with a heated humidifier to facilitate CO2 clearance. And it worked well compared to NIV and high flow. So I think it's reasonable, no?
Yes, I agree with you, Domenico.
Despite the conflict of interest.
Last question, because it's, yeah.
My question is regarding those patients who are practically we had those patients who are ready to be extubated. They are on low ventilatory support, FiO2 less than 30%, low PEEP. Even they passed the spontaneous breathing trial without or low ASB, but still failing extubation. Generally, they are quite weak. They have got some myopathy. What parameters are you using to determine whether this patient is ready really to be extubated? In my practice, I, for example, use the P01, but my experience is that really doesn't help.
So P.1 is a measure of drive. So it's just the first 100 milliseconds of occlusion, and it mostly reflects the neural output. It's not so perfect, but I mean, it reflects the drive. I understood that you are looking for a measure that estimates the strength. I think there is no validated, at least non-invasively. What I can suggest, and what we do sometimes, I know it's not validated, but we found that at least in clinical practice it works. We perform a prolonged occlusion on the vent, and you have different patterns. There are patients that make a first effort, which is as an amplitude, and then the same amplitude for the 6 efforts. So that means that the patient has no reserve to increase the effort. And there are others, like young, healthy subjects, that go to minus 50. So this is a kind of a maximal inspiratory pressure during an occlusion normalized to the first breath. So the behavior of the negative deflection in airway pressure during a prolonged occlusion, it can increase or remain the same. If increases, it may seem that the patient can increase the effort in case it is needed. So that could be a kind of a measure of the reserve of the muscles.
Okay, we have finished the session. Yeah, and your patient has weak cough or adequate cough, or because I think more than respiratory muscles, the most important is cough strength. And these patients had an increased risk of reintubation, and in the recent meta-analysis is 35-40%. Patients with weak cough have probably the most patient at high risk of extubation failure. And I think this point is probably, in my opinion, more important than strength of respiratory muscles. But okay.
Consider then tracheostomy?
For sure, in these patients, I don't have, in my experience, I try a first attempt of extubation. And then in case of, in the prior question, if the patient is able to breathe without the ventilator for spontaneous breathing trial, but reintubation in case of myopathy, or, for example, the patients at high risk, myasthenia or Guillain-Barré syndrome, etc., etc. I try. It depends on the patient, but I try an attempt of extubation, and then I propose tracheostomy. But it's just
I think nobody's up.
Do you consider diaphragmatic pacing when it comes to possibly improving or rather avoiding failure of extubation?
no. No, we don't have data. It's just for research. Maybe it will be interesting, but up until now, it's not.
And maybe I'm not an expert, but in my understanding, diaphragmatic pacing is needed before to avoid development of weakness, not at the extubation phase.
You're right.
Okay.
And
Maybe. Okay. So transvenous. Okay. So thank you very much.